say you have narrowed down into like a specialty or an area of the body that you're just most comfortable with?
Yeah, I wouldn't say it's a specialty. Like, I'm more comfortable with lower limb injuries purely based off my background of sports that I've worked in. Like rugby, you see a bit of everything. So like I've seen plenty of upper limb traumatic injuries, but netball and basketball inherently are mostly lower limb injuries. And so that's what I feel more comfortable with. And like netball and basketball, the first thing you think of is ankles typically, and then knees. Yeah. So that's what I've seen most of, and that's probably where I'm more comfortable, but yeah.
Okay. Would you have kind of a rare case study that you could share? Something that is not commonly seen.
Okay. Doesn't have to be sports-based. Can be musculoskeletal.
Yeah.
Yep. I have had a patient for quite a while now who, in lockdown, decided that skateboarding would be a fun thing to try. She's around 40 years old. Jumped on a skateboard, came off the skateboard and injured both ankles. So her left ankle, she had a moderate to high grade lateral ligament injury. And then her right ankle, she dislocated.
Oh, okay.
So she ended up with a plate up her fibula, so a fracture on her fibula, so a plate and screws. She ended up with a syndesmosis injury, so she had a screw right the way through tib for a while. And then she had a bimalleolar fracture of her right ankle. So she had surgery on that ankle, and then she had high-grade lateral ligament injury of her left side. That was probably about a year ago now that all happened. So since then, there's some hardware that's come out, but it's been a really tricky process building strength and capacity back up, particularly in the right ankle. A very traumatic injury, unfortunately. There's been some slower healing than expected, and she's had issues with ongoing swelling due to the nature of her jobs on her feet, unfortunately. And so she returned back to work, but that load was too much, and it's been tricky to manage. And we've had real wins throughout it, and then real tanks throughout it, and real wins throughout it, and real tanks throughout it. So it's been a challenging one for me.
Yeah. Did she present to you acutely?
She came in about 2 months post-injury. So
Post-surgery?
Yes.
Post-surgery?
Yeah. So when she injured it, went straight to the hospital and got operated on pretty quickly, and she was non-weight bearing for 6 weeks on her operated side. She couldn't weight bear very well on her other side, so she was on a little scooter for a while. But we saw her when the syndesmosis screw got removed, and that's when I first saw her.
Okay. And when someone is so acutely post-op, what is your assessment like?
It's pretty limited, to be honest. She'd transitioned from a cast into a boot, and she hadn't really been weight bearing at all. The assessment, the extent of a functional assessment could be, could she stand on it? Could she walk? Could she balance? And that was about the extent of it. And then you're quite limited by going, okay, well, often if I'm a bit stuck or if there's so much going on, I'll go back to the fundamentals of, okay, can they move it? Active range of motion. Can I move it? Passive range of motion. Can they resist? Like a manual muscle test. And then just start there.
So you would still go through all those movements, even with kind of plates and screws in there?
Yeah, just see where they're at. If they've been cleared to start physio by a surgeon, that means the surgeon's happy to get them moving. Mm-hmm. And often there's, the surgeon will have protocols on how quickly that can happen. And it's different for different injuries. But you want to see what they can do day one. You don't want to push them. And you don't want to be causing them pain because you want them to come back. Mm-hmm. But you want to be seeing where they're at, even if it's this much of an assessment of what you might usually look at as more.
Okay.
Yeah.
What was, just generally, what was that progress like throughout the past year?
Sometimes it would progress slowly, but progress. One of the biggest issues has been her dorsiflexion range of motion. So her knee to wall, it took a long time to even get to 0 centimetres, so just toes against the wall. And then knee to the wall, and then it improved for a bit, and along with that, her like function and being able to like calf raise, for example, on 2 feet, then to 1 foot improved. And then she unfortunately started getting these like sharper symptoms of the anterior joint line. She had a few screws from posterior to anterior through the tibia, because one of her fractures was at the back, and her dorsiflexion range then went back down, and her function decreased, and she had more swelling. And so at that point, she got another screw taken out because it was extruding into the joint line. And so then, like, it's been a real tricky one.
Yeah.
Yeah.
Okay. Any tips on how to manage tricky presentations like this?
I think tricky presentations, like knowing they're never going to be a quick recovery. If someone has an injury that traumatic, it's not going to be 6 weeks in a cast and you're sweet. Like, it's going to be a long recovery. They're likely to have sort of something at their ankle they're going to have to manage ongoing. I think, like I said, if you're not sure where to start, then just go back to basics. What can they do? Can they move it? And go, okay, well, I know they're a bit weak here, so let's just work there. There might be 20 other things that you need to work on, but work on one thing at a time, rather than going, I've got to address 20 different things with 4 exercises, because that's not going to happen.
Yep.
And I think if it's not progressing, or if it starts to go backwards, you've got to go, well, why? And you've got to go, if it's not progressing as you expect, do you need to scan it? Does it need, like, should you get someone else's opinion? Like, should you get a different surgeon's opinion? Should you see a sports doctor? Like, we're, again, at Zone, we'll use each other. Like, I'll be like, cool, I'm going to talk to one of my colleagues who is very good with foot and ankle, and go, what should I be looking at here? Should I look at something else? Do we need to get an injection? Should I scan? What direction could we go? And, like, it's using the people around you and using all the knowledge around you, I think, is the best way to go about it. Yeah.
Okay. When someone's got screws in a joint, is it safe to do MOBs?
So she didn't have screws in her joint. She had screws in the tibia.
Okay, yep.
So talocrural joint, she had screws through here.
Okay, yep.
So in that sense, yes.
Yes.
What had happened with her was she was getting sharp pains into dorsiflexion at a point where she didn't have an injury. And initially, the first thing you go, okay, maybe it's just some anterior impingement. There's some swelling going on perhaps that's causing something to happen. And it was the sharp pains that I was like, I don't like that. Like, that's unusual. And every time I went into dorsiflexion, it was there.
Yeah.
And at some point, you've got to go, well, let's scan it and see what's going on. So we got an MRI at that point. And that's when it revealed that there was a screw that was poking into the joint. And in which case, if there's a screw poking into a joint, I would not be moving it.
Yeah. Okay.
But depends on where the screws are. They don't usually screw so it comes into the joint.
Yeah. And so if you were talking about increasing her dorsiflexion range at the start, what were some techniques that you were using?
A range of things. It depends on whether you feel the dorsiflexion range is joint or soft tissue, or a combination of both. You can have capsular tightness, that sort of thing as well. So we used soft tissue because certainly there was an element of her calf was restricting her amount of range in dorsiflexion. And then joint MOBs, so AP, talocrural MOBs. You can do tib-fib MOBs, but for her I didn't because she had the syndesmosis injury. Yeah, joint mobilisation, PNF stretches sometimes for the front of the ankle, so to improve plantar flexion, so going the other way. But yeah, soft tissue, joint MOBs, a range of different joint MOBs.
Yeah. Okay. You touched on how ankles, kind of something you see a lot of. Lateral ankle sprains is a very common injury. So just kind of want to pick your brain here. If you see someone, from the moment they roll their ankle in, what's kind of your first line of thought, or first thing that you would do?
So, say for example, this happened at port,
Mm-hmm.
and someone came over going, I just rolled my ankle. First thing I would look at is, can they walk on it? Number one, if they can weight bear, that's a really good sign.
Mm-hmm.
If they can't weight bear, then you're obviously thinking it's going to be something more serious. And then if they can weight bear, how well can they weight bear? Can they move on it? But you'd be questioning a bit more, okay, well, how did you injure it? If it's an inversion injury, you go, okay, well, where's your pain? Is it on the outside? Is it on the inside? Is it in the foot? Is it further up? Because that's going to change potentially what structures you're thinking might be implicated with the injury.
Okay.
Yeah.
So you just mentioned kind of four there, so of the location of pain.
Mm.
So I think the first one you said was, is it outside
Mm-hmm.
of the, or no, is it in the foot? If it's in the foot,
Mm-hmm.
what would you be thinking?
Again, it depends on where in the foot you're talking
right,
about.
okay.
So if it's, can I go back to lateral first?
Yeah, yeah.
So lateral's the first obvious place that you'd expect it to be. Like lateral, like an inversion injury, you go, okay, well, it's probably a lateral ligament injury, and most of the time it's going to be.
Mm-hmm.
So that's where you expect the pain to be. So if they're going, yep, the pain's on the outside, then you go, okay, that makes sense. If they're going, oh, the pain's a bit further down the outside of my foot rather than at my ankle, you start to think, okay, well, has there been an injury to the base of the fifth metatarsal? The perineal's avulsed something off. Has there been an injury to one of the lateral midfoot ligaments, such as bifurcate ligament? And so you're starting to think of differential diagnoses based on the area of pain. If the pain is more medial ankle, so they've rolled in, stretched the outside, but have they got a compression injury on the inside? Have they just compressed soft tissue, or have they banged the bone together and caused some bony bruising or some sort of lesion there? So you want to look at that. If it's medial foot, navicular would be the first one you want to think of.
A fracture? A navicular?
Yeah, it can be. Yep. So navicular is, palpating the navicular is one of your Ottawa ankle rules. Yep. So you always want to clear that. And then if the pain's a bit higher up through their shin, are you thinking maybe instead of a lateral ligament injury, it's a high ankle sprain? So still lateral ligament, but high ankle sprain, which obviously will change your management.
Yeah. After kind of figuring out where their pain is, where do you go from there?
I would be looking at the integrity of the ligaments. So I'd be looking at my ligament tests.
Okay.
So knowing and being confident in your clinical testing is really important. And again, it comes with experience of the more ankles you play with, the better you get at it. And the more you get to feel, okay, well, is this loose or is this not? And comparing to the other side. So I'll either go straight into that or I'll go straight into palpation. And being quite systematic on how you palpate, I think means that you're not going to miss things. Because it's really easy to go, okay, well, their pain's lateral, so I'm going to go straight for the lateral. But going, okay, well, I've got all these things I want to tick off. And even if they're looking at you like you're crazy because they're going, well, my ankle hurts on the outside, and you're poking the inside of their foot because you're checking their navicular, and they're going, this person doesn't know what they're doing. It's more for you to go, okay, well, I'm making sure that I'm clearing things that could be a bit more of a serious injury.
Yeah.
Compared to, or things that might influence your decision making as to, do you need to get it scanned? Can you try them, back on the court?
Yeah.
Depending on the severity of how they're presenting.
Okay. So what about, the textbook, AROM, PROM, IMT, all that stuff? Do you do that then and there as well? Or is that more for later?
Yeah, you can do. I think active range of motion tells you a lot pretty quickly. Usually with your inversion injuries, they're not going to like plantar flexion inversion because that's going to stress out the lateral ligaments. And like I said, most of the time it is a lateral ligament injury. But it'll tell you a bit, particularly if you go into dorsiflexion and eversion. What are you more suspicious of?
Dorsiflexion and eversion, kind of like your Tom, Dick and Harry?
Yep, maybe a little bit.
On the medial
Ligament-wise, what are you thinking if it's dorsiflexion, eversion?
Deltoid.
Yeah, a little bit,
because of the eversion part?
Yep.
That's not the answer you're looking for, is it?
No. So if you've got someone who who's got pain or positive dorsiflex an eversion test.
Where's the pain at? Sorry.
Out on the outside?
On the outside. Would it be a syndesmosis?
Yeah, you'd be suspicious of that. So active range of motion can tell you a little bit about what structures potentially might be implicated, but it's not the most specific or sensitive thing with an ankle injury. So it might be positive, but it doesn't automatically rule in a high ankle sprain or a syndesmosis injury.
So if you were to prioritize all the different things you could do in an assessment, what are the 5 most important things that would tell you the most if you could only do 5 things?
Okay. Weight bearing status.
Okay.
Palpation, ligament test. I'm probably looking at things like active range of motion, perhaps a manual muscle test or a dynamometry test at a push. I don't do that with everyone. The top 3, weight bearing status, palpation, ligament tests probably come together.
Yeah, okay.
Yeah.
Cool. Are you happy to go through the palpation and some of the special tests that you mentioned?
Yeah, for sure. Do you want to?
Okay.
Yeah. All right. So I'll go through the main ones I would do. So first one for your ATFL is what? I'm going to test you out here.
I know it's this one.
Anterior draw.
Anterior draw.
So your anterior draw test. So you're looking at your ATFL here. So you're trying to get an anterior translation of the talus on the fibula / tibia. So I do all of my special tests and palpation in a seated position with their foot hanging down, which is a bit different to how they're taught at uni, or certainly I was taught at uni. And the reason being is I found it very difficult long sitting with your foot up, because I find people can't relax very well in that position. And my hands are small and I couldn't manipulate very well and get a good feel. Whereas in this position, people tend to be pretty relaxed. Just step forward slightly, Justin. Yeah. So people tend to be pretty relaxed in this position. The foot kind of just hangs. They're not really, tensing up and holding their foot and being quite sore, or being quite apprehensive, I should say. But they can relax, and it also provides a little bit of traction through the joint, and so you get a better feel of their play. And I don't need to use nearly as much force to get a good test. So anterior draw, so looking at ATFL. So I will use one hand to stabilise proximally, and then I'll grab around the back of the calcaneum, front of the talus, and just get anterior draw. So you can see Justin's got pretty solid end feel on his, and the more tests you do, the better you get at feeling, okay, well, is it lax, is it not? So simple, one there, pull forward. You don't need to use much force to get a good feel of what's going on.
Okay.
CFL, so you're looking at calcaneum fibula. Again, you want to block one side. So I will block from medially with one hand, and then from this hand, I will try and translate across. So I'm doing more of a that movement rather than a tilt, because I think this position gets too much inversion here, and you're going to be stretching out your ATFL, so you will likely get a false positive if you're constantly doing this.
Okay.
So I will tend to go, you see how that's far more
and there's an end feel there too.
Local, and there's an end feel. You can see it spring back on itself.
Yeah, okay.
So that's your CFL. AITFL is your dorsiflexion eversion test alongside some other tests. So you want to use a battery for that one. I find this position, or I'll do this one in prone sometimes, is you can get up and under, so you can get them into dorsiflexion pretty well, and then you can just twist them out into eversion. Sometimes it can be a bit sore if you're jamming them right the way up, so you can always test them here and go, okay, well, if that's reproducing their pain already and their pain's up here, you're getting a bit suspicious. Of AITFL. Yeah.
So syndesmosis as well?
Yeah, AITFL, syndesmosis.
Yeah, okay.
So if doing it in neutral first is reproducing high ankle pain, you're a bit suspicious. if they're not too, if their pain's not too provocative, you can jam them up into dorsiflexion and then go. But that's a bit more aggressive.
Okay.
Yeah. So that's your ATFL, CFL, ITFL. What ligament sits down here? There's a few of them.
Liz Frank. No?
Liz Frank is base of your first and second metatarsal on the cuneiform.
Okay.
So that's different. I'm thinking lateral ligament.
Bifurcate.
Bifurcate ligament. So your bifurcate ligament attaches onto the anterior process of the calcaneus, onto your cuboid and one of your cuneiforms. Okay, so your bifurcate ligament test, you're going to be winding them up into supination, so midfoot supination, and then your adducting, so adduction. So you want to block the calcaneum. You're going to bring yourself down into supination. So you really need to get a good grab of their foot. Just be careful where you're pushing. So, and then you're adducting. So you can see there's a little bit of movement there naturally, but there shouldn't be heaps.
Okay.
There's also another little ligament down here that's your calcaneocuboid ligament, and that test is a pure adduction.
Without the supination.
Without the supination.
Okay.
Yeah. So deltoid ligament is more of a fan ligament on the medial aspect of the ankle. And so you can test it out in kind of the opposite way you might test for your lateral ligaments. So you can, if you're looking at more these medial structures, you might want to do the opposite of your talar tilt and push you in that way. You can test and stress it out in different ways. You can bias an anterior draw more to an inside. So you can just play around with positionings. But your deltoid ligament is far thicker and far stronger than your lateral ligaments and is less often injured.
Okay.
Yeah.
Cool. That was awesome.
Okay, so palpation of the ankle. Number one, what are your Ottawa ankle rules?
Base of the fifth actual weight bearing, I think 5 steps it was.
Yep.
And then tenderness on palpation over the medial or lateral malleolus. Base of the fifth, or navicular.
Yep. So ability to weight bear is number one. So base of the fifth, obviously you can come down along the fifth metatarsal. What attaches to the base of the fifth, Justin?
Peroneals.
Yep. So your peroneal tendons will attach to the base of your fifth. So sometimes with lateral ankle injuries, you can get an avulsion of the base of the fifth, or you can be getting further up the base of the fifth, you can get little Jones fractures. So palpating around the base of the fifth, navicular, to this foot. The navicular, so you can find tubercle here, so you can poke in and around there, but then if you dorsiflex for me, Justin, so you'll see the tib post tendon come up, and you can come to the lateral side of that tendon, then relax. So you're still on the navicular there. So you should feel like you've got a bit of a chunk of bone there. It's a pretty big bone, the navicular, but you can poke in and around the navicular there.
Okay.
Posterior aspect of the tibia and fibula. So I think the Ottawa ankle rules say extend up 6 centimetres up the back of the fibula. So here, palpating down, watching that you're not palpating peroneal tendons, which are also very close in that region. So you want to make sure you're on bone and not tendon. So palpating down and then palpating down the other end. So on the inside there. Okay. So coming down and around. So that's your Ottawa ankle rules. In terms of ligament, I tend to be quite specific in terms of where in the ligament I'm palpating. So I don't just go straight in. I will start up higher and come down through syndesmosis towards AITFL first.
How do you find the syndesmosis?
Visualize the anatomy.
Okay, cool.
is how I do it, because it's going to be underneath soft tissue, in reality. But you can come down through the front of the fibula, and you know that if you drop a little bit in from there, you're going to be around that point.
Okay.
Okay, so coming down, and then at the base there you've got your AITFL, so between the fibula and the tibia. And then what I will do is I will drop around to the front of the fibula. So I'm on the proximal attachment here of your ATFL. And so sometimes people will avulse that, and so they can be a bit tender over the proximal side. And then from there, you can go, okay, well, I'm on the proximal bony attachment. I'm going to be on mid-substance as I drop in. And then as you hit the talus, you know, you're on the distal attachment.
Okay.
So you can kind of go, okay, well, is it attachment? Is it mid-substance? And you can start to get a bit specific in that sense. Similar, you can come right the way around onto the end of the fibula. You know that the CFL runs down, so you can go, okay, well, bony, drop into the joint space, that's mid-substance, and then drop onto the bone, that's going to be distal attachment. From there, if you're wanting to palpate your bifurcate ligament, so bifurcate ligament attaches onto the anterior process of the calcaneum. So you can drop off the end of the fibula, and you want to drop forwards slightly, and you'll find a bit of a bony bump. Okay. So that's the anterior process of the calcaneum. So you're on one of the attachments, and you know if you go forwards, you're then going to hit cuboid. So you're poking around in here, you're going to be on your bifurcate ligament. It can be a bit tender sometimes. It's often missed with lateral ankle injuries, because people will stop and just assume that it's up here, but they won't assess further.
Yeah.
So I'll do a similar thing on the medial side. So I'll come down around the malleolus and try and stick to the bony side. And if they're particularly tender at any of the points, I'll be like, okay, well, let's drop down and see if it's ligament or is it joint space or hard to tell. You can drop onto the talus from there. But what I will also do is I'll have a poke through medial talar dome. Because often with your lateral ligament injuries, you've rolled this way, so you've stretched this side, but you compress this side, so you can get tenderness through there.
Okay.
So you want to poke through there. And then you can come along the top of the joint line, so the base of the tibia. You can come into the taloacrural joint line, so you can feel like a big divot through there, and then you can roll onto your talus. And if you put them into plantar flexion, your talus pokes out a bit more, so you can poke onto there. So it's all about knowing your anatomy and knowing what you're poking at, being specific on it. Going, is it bone? Is it joint space? Is it bone? Is it ligament? Is it attachment? Is it? So you can get a bit more specific on that.
Yeah. So when you were talking about the compression and the bifurcate as well, so separately.
Yep.
If they're both positive and you find tenderness through that, does that kind of affect your rehab much?
If there's ongoing tenderness medially, then you've probably got a high suspicion that there could be like some bony bruising or soft tissue injury across this side. So you can bang the bones together, but you can also compress the soft tissue in here. So you can pinch the deltoid ligament, or you can pinch, say, a tib post tendon might get caught in around the back. If there's bony bruising, for example, that's going to slow you down because it might not tolerate impact as quickly as what just a lateral ligament injury will. So it's going to be a bit longer with the rehab process.
Okay. And bifurcate?
Bifurcate, again, it depends on the degree of the injury to the bifurcate. Often I'll find you can still progress them pretty well because it's a ligament injury rather than bony involvement. So you can still progress them pretty well at the same pace, but knowing that when you get to change of direction, particularly a sharp change of direction, they're going to probably either be a bit slower or struggle with that, or they're not going to like the feeling of it. And sometimes what we'll do is we'll add taping down around the midfoot. So we might basket weave, or we might add a midfoot lock over that to provide a bit more stability. But because it's ligament rather than bone, our rehab timeframes mightn't change too much.
Okay.
But it's useful to know that it's there.
Yes. Okay. Cool. That was super awesome. Thanks, Alice.
No worries.
So with your lateral ankle sprains, just kind of loosely, how does your rehab plan look like? Say it's a pretty severe one, like a moderate to severe lateral ankle sprain.
Okay. We'd usually split it into different phases. So we'd go, okay, well, we want to protect and optimally load. So that's like your initial very acute phase. And then you go, okay, well, we want to start getting back the strength and stability. So that might be the next phase. And then you go, okay, well, once they've gone through that phase, we have exit criteria, like objective. Like, okay, well, we might want their knee to wall to be within 2 centimetres of their normal, and we want them to be able to do 25 single leg calf raises, and their seated calf strength on a force plate needs to be within 80% of what their normal was, or 80% of their right side. And then we go, okay, well, let's intro to impact. So let's get a bit of plyometric load into them and see how it tolerates that. Once they can do that, and again, there's exit criteria. We start them to run again, and then we build through, okay, run straight lines. Can you run curves? Can you change direction? Can you accelerate? Can you decelerate? And then within that, we've also got to be thinking, okay, well, what sort of, for example, in a King's context, what sort of basketball skills can they do in that? At what point can they start doing stationary shooting? At what point can they start doing spot shooting where they've got to jump to shoot the ball? At what point can they start doing shots on the move? At what point can they begin to feed back into offensive drills? At what point do we start them on like a one-on-one kind of context? And so all of that then feeds into how we then feed them into training, and often it's a drip feed approach.
Yeah.
So they might do a bit with the team and a bit with us, and then a bit with the team and a bit with us. Yeah.
So you've touched on a few things here. You've touched on the exit criterias for the different phases. Is it too complicated to be going through the numerous exit criterias?
There's a lot.
Yeah, okay.
I reckon what you're wanting to be looking at is going, okay, well, they've got to be passing certain strength markers in terms of seated, like we look at seated calf raise endurance, seated calf raise strength.
Through the with force plates?
Force plates, yeah. We want them to be able to single leg calf rise. But then we've got to look at, okay, well, what's their linear hop? What's their triple hop? Can they do repeat lateral hops? Like we look at stuff like that as well.
And what are the numbers that you're looking for? Do you have them off the top of your head?
It's different with different populations. Like there is normative data out there, but
is it left compared versus right most of the time?
Yeah, most of the time we'll go limb symmetry index. So we want it over 90% limb symmetry. So are they within 10% of their other side?
Okay.
5% if we're being picky.
Yeah.
But then I think the beauty of working with teams is often you'll have pre-season screens, or you'll have results that they might have had from a previous injury, so you know what their baseline is. And so if their baseline's here and they're going, oh cool, but I'm within 10%, but they're only hitting here, you go, yeah, but you should be hitting here. And that's where like we can track over time. It's like Tobes was talking about force plate data. As you track it over time, you know where they should be hitting. And if they're not hitting it, you're going, well, why aren't they hitting it? Does that make sense?
Yeah. Last question for you. If you could get one person on this podcast, who would it be?
That's a tricky one. Yeah, I reckon, does it have to be sport? Like, what are we talking about here?
We're aiming for sports physio, but if you've got another one that you think would be good, I'm happy to.
I reckon, so I'm going to throw one of my colleagues under the bus. We're very lucky to have one of our colleagues, her name's Bernie Petzel. She is currently doing a specialisation as a sports physio, so she's gone through sports masters, and this is like the next level on top. Very few physios become a specialised physio. So she's incredibly knowledgeable. She's gone to Paralympics. She works with para-athletes for Athletics Australia. She works with NSWIS. She's got a lot of history with military populations, so she's got such a broad range. I think she'd have some gems for you.
Awesome.
Yeah.
Okay, I'm looking forward to talk to her.
She's going to love me for that.
Anyways, thank you so much for your time today, Alice.
No problem.
Really appreciate it.
Yeah, great to be on here. Cool chat.
You were awesome today.
Thanks, mate.